I'd like to introduce our first presenter this evening, Jenna Taylor. Jenna is a PhD candidate and an NHMRC postgraduate scholarship recipient with the School of Human Movement and Nutrition Sciences at the University of Queensland. Her research interest in cardiac rehabilitation stems from her career as an exercise physiologist and dietitian within the Cardiac Rehabilitation Unit at the Wesley Hospital. Specifically, her interests involve the effect of high-intensity interval training on fitness, vascular health, abdominal obesity, and other metabolic processes that play a role in the prevention and management of cardiovascular disease. With a strong clinical background, translation of findings into practice is an important focus of her research. Please welcome Jenna Taylor.
Thank you for the opportunity to present tonight. I'm really excited to share my research findings. So to set the scene in terms of cardiac rehab, heart disease, which involves the buildup of plaque in the arteries, is the leading cause of death and disease burden in Australia. 1/3 of all heart attacks are repeat events, and cardiac rehab has been shown to reduce hospital readmission and death within the first year. Exercise plays an important role, and to date, the main prescription has been moderate intensity continuous training. Now, the reason why exercise plays such an important role is this strong correlation between cardiorespiratory fitness and survival. This study in over 12,000 heart disease patients showed that for every 1 ml per kilo per minute increase in fitness, this improves survival in years by 9%. And we measure cardiorespiratory fitness as VO2 max in a maximal exercise test. And VO2 max is essentially the amount of oxygen a person can consume and utilise. So we measure this through gas analysis, through a mouthpiece or a mask, and it measures the amount of oxygen coming in and the amount of carbon dioxide going out. And usually during a maximal exercise test, we also use 12-lead ECG to monitor safety. So the interest in high-intensity interval training really stemmed from this original research paper in 2004 by a Norwegian group of researchers. They compared high-intensity interval training, or HIIT, with moderate intensity continuous training, or MIT, and basically showed that HIIT doubles the improvement in fitness compared with MIT. So what is high-intensity interval training? So it's defined as alternating periods of high-intensity exercise, or anaerobic exercise, with periods of lower intensity exercise or no exercise. And you might have seen the documentary by Michael Mosley on HIIT, but if you haven't, I'll bring you up to speed.
Sprinting, that's looking really good. Really good. Excellent. Keep it going. You're halfway.
Keep it going.
5 seconds to go. 3, 2, 1.
But you'll be glad to know that that's actually not HIIT. So that's what we call sprint interval training. So sprint interval training actually involves maximal efforts or supramaximal efforts, whereas high-intensity interval training is still below maximum at about 85 to 95% of your maximum effort. And if we have a look at this RPE chart, which stands for rating of perceived effort, with 6 being no effort at all and 20 being a maximal effort, SIT really sits down at this 19 to 20 mark, whereas HIIT is prescribed at an RPE of 15 to 17, hard to very hard. And to put that into perspective, MIT is often prescribed at an RPE of 11 to 13, which is fairly light to somewhat hard. But it's so important to understand that HIIT is relative to the patient. So in other words, an RPE of 15 to 17 for an athlete would be a very different workload to an RPE of 15 to 17 for a patient with heart failure. So often HIIT can be achieved in most clinical patients by walking on incline on a treadmill. So a common concern in the world of HIIT is is it safe? So this study in 2012 is the largest study available to answer this question, and it looked at over 5,000 heart disease patients. So over 175,000 training hours, they found that there was 1 fatal cardiac arrest in the moderate group and 2 non-fatal cardiac arrests in the HIIT group. So the study concluded that there was a low risk in both groups. However, there was actually a higher risk of mortality or death in the moderate group compared to the HIIT group, even though the HIIT group had a slightly higher risk of an actual cardiac event. So in terms of this research, our main questions were, is HIIT superior to MIT for fitness in a hospital-based cardiac rehab program? Because to date, most of the studies had actually still been in labs. We also wanted to know, is HIIT feasible and safe compared to MIT? And can HIIT actually be maintained following a cardiac rehab program in a home-based setting? We were also interested in blood vessel or vascular function. And one of the ways we measure this is through a technique called brachial artery flow-mediated dilation, or FMD. So basically we use an ultrasound on the brachial artery, and we can measure the ability of the artery to dilate in response to a stress. Now the stress that we use is simulated by a cuff that we place around the elbow, which we inflate for 5 minutes to occlude the blood supply. But when we release the cuff, the artery then dilates, and we can see the maximum response that the artery can dilate. So we actually calculate a percentage between the baseline diameter and the maximal response diameter. And just to put that into perspective, a healthy FMD would be about 6 to 7%, but in unhealthy vessels it can be as low as 0%. And research has shown that an increase in FMD by 1% can reduce the risk of future cardiovascular events. We were also interested in abdominal obesity, which is a major risk factor for heart disease. And we know that not all fat is created equal, and it's actually the visceral fat, which is the deep fat that surrounds our organs, which is the most dangerous for our heart. The reason being is that this visceral fat releases a whole host of hormones and inflammatory substances which can increase the progression of heart disease. Now, the gold standard method for measuring visceral fat is actually MRI or CT. And the protocol that we use is multiple slices from the pelvis to the diaphragm in order to calculate the total visceral fat volume. This is an example of an MRI slice where we've used the semi-automated software to measure the subcutaneous fat in yellow and the visceral fat in red. And actually, there's been no studies to date that have compared HIIT and MIT on visceral fat in heart disease patients. Another thing that we can measure during the MRI scan is actually liver fat through a technique called magnetic resonance spectroscopy. So really then we developed this study in order to answer the questions. So our study, the Fitter Heart study, looked at questions such as feasibility, safety, adherence, and efficacy in terms of fitness, vascular health, and visceral fat. So this was a collaborative effort between the Wesley Hospital Cardiac Rehab Program, the University of Queensland, and the Centre of Advanced Imaging as they did the MRI scans. So this was a randomised control trial, which means that the participants were randomly allocated to either HIIT, the intervention exercise protocol, or MIT, the usual care exercise protocol. They didn't get a choice as to which one they wanted to do. So participants were provided with study information at their initial cardiac rehab appointment, and then those that were interested were then screened for eligibility. So to be eligible, they had to have angiographically proven coronary artery disease and be 80 years old or less. We did have some 80-year-olds, and have no exclusions. So all participants were screened by the study medical advisor, and their baseline exercise test was supervised by a doctor. Also, the treating cardiologist was informed of the participants' participation with the opportunity to exclude involvement. So following the randomisation into the groups, the participants then completed the 4-week cardiac rehab program, which included 2 supervised sessions and 1 home-based session per week. In terms of the exercise training, the usual care moderate intensity program involves 3-minute warm-up and 3-minute cool-down, and in between 34 minutes of moderate intensity exercise, with a total session of 40 minutes. Our HIIT protocol involves similar warm-up and cool-down, and in between 4 bouts of 4-minute high-intensity intervals at an RPE of 15 to 18, hard to very hard. And this is interspersed with 3-minute active recovery intervals for a session duration of 32 minutes. And then following the supervised phase, participants were then instructed to continue 3 home-based sessions per week for a further 11 months, with follow-up testing at 3 months, 6 months and 12 months. In terms of the outcome measures that were performed at each testing time point, we looked at cardiorespiratory fitness, vascular function, body weight and composition, cardiovascular risk factors, dietary intake and behaviour, heart rate variability, and physical activity levels. As well as that, we then performed the MRI measurements at baseline 3 months and 12 months, which looked at the visceral fat and the liver fat. And then following commencement of the training, we then followed up in terms of the feasibility by participant questionnaires, safety in terms of the serious adverse events, and then exercise adherence and compliance from supervised exercise records, weekly exercise logs, and participant questionnaires. So now for the results. So in terms of recruitment, during the 18-month period, there was a total of 406 patients referred to cardiac rehab, and 290 of those had coronary artery disease. 178 patients declined to participate, and 16 were excluded for medical reasons, leaving 96 patients to be recruited. We had to exclude 3 participants at baseline testing due to an abnormal stress test, which left 93 participants to be randomised. So in terms of baseline characteristics, there was 46 participants randomised to HIIT and 47 randomised to MIT. Both groups had an average age of around 65, had a low to average fitness level, had a BMI in the overweight range, and had a low prevalence of female participation, diabetes, and smoking. In terms of feasibility, participants were asked to rate their exercise protocol in terms of the following questions. And this was on a 7-point Likert scale. So you can see here, there was high scores in terms of the confidence in performing the exercise protocol, the ease of instructions to understand, the ability to manage intensity, and the enjoyment of exercise. And so that was following the supervised training, and now following the home-based training, you can see that the feasibility scores were actually very similar. Now, in terms of safety, so there was 9 serious adverse events reported throughout the study period, and they were reported to the ethics committee. However, all events were deemed to be unrelated to the exercise protocol as per their treating cardiologist. Only one of the events actually occurred during an exercise session, and that was the hypotension, so the low blood pressure. So in total, there were 6 events in the HIIT group and 3 events in the MIT group, but they were all considered to be usual following a cardiac event or intervention. And then also in terms of mild to moderate adverse events with exercise, this was also similar between the groups. So this was regard to symptoms such as chest pain, lightheadedness, joint pain, muscle soreness. In terms of adherence to the intensity of the protocol, this was very high in both groups. So we had 91% adherence in the HIIT group and 98% adherence in the MIT group during the supervised training. It was also important to see that there was a significant difference between the groups in terms of the training intensities. So you can see the average training intensity for the HIIT group was 16 and the average training intensity for MIT was 12, which was within the ideal ranges. Then if we look at the home-based training, there was still a high adherence to the prescribed intensity. So we had 84% with HIIT and 88% with MIT. And in terms of the training intensities for HIIT and the heart rate ranges, they were very similar to the supervised program, showing that that level of intensity could still be maintained in a home-based setting. Now when we look at the adherence to the number of sessions of the randomised training. So during the supervised phase, this was very high. There was 91% in both groups. However, in terms of the total weekly exercise sessions, the MIT group was significantly higher than the HIIT group, as they were averaging 4 sessions per week instead of the recommended 3 sessions per week. This also showed in the weekly exercise minutes. So MIT was doing close to 200 minutes per week on average, and the HIIT group was doing on average 125 minutes per week, which was significantly different. And then if we look at the adherence to the randomised protocol over the duration of the study, by 12 months, there was only 53% adherence in the HIIT group and 41% adherence in the MIT group. Now, one of the main reasons for that is that there started to become a bit of crossover in the groups. So there was 20% of people in the HIIT group that decided to start doing moderate intensity training. And there was actually 36% of MIT participants who started doing high intensity training. So this is a real world study, right? So, but what you can see is that they still managed to do on average 3 exercise sessions per week. It just wasn't necessarily the randomised training they were supposed to do. So now I'll present the results for the cardiorespiratory fitness. So on the y-axis, you can see that I'll be presenting the change in fitness from baseline at each different time point. So HIIT will be in the blue bars and orange will be the MIT. MIT will be in the orange bars. And just remember what I said earlier about 1 mil per kilo per minute being a clinically meaningful amount. So after 4 weeks of the cardiac rehab program, we can see that there was a significant improvement in HIIT in terms of fitness compared to the MIT group, which was statistically significant. So HIIT increased by 2.9 mils per kilo per minute in just 4 weeks, and the MIT group improved by 1.2 mils per kilo per minute. Now, over the 12 months, the groups did get closer together and it was no longer statistically significant at 12 months. However, there was still a 1 mil per kilo per minute difference between the groups. Now, we did a per protocol analysis considering the amount of switching between the groups. So what this does is it just accounts for the patients that were doing the randomised training they were supposed to do. So what we actually find is that both groups again improve over the 12 months. However, you start to see that bigger difference in the HIIT group with the fitness. So that's now a difference of 3 mils per kilo per minute. And that could be equivalent to a 30% improvement in survival. Now, in terms of vascular function at 4 weeks, you can also see that there was a significant improvement with HIIT compared to MIT. So HIIT improved by 1.5% for the FMD, and MIT, there was virtually no change. Over 12 months, again, you see the difference between the groups come back together. But HIIT did still maintain that clinically meaningful increase of 1%. When we're looking at visceral fat, this was measured at 3 months and 12 months, and we didn't see any difference between the groups in terms of visceral fat. So, however, there was still a reduction in both groups. So the HIIT group reduced visceral fat at 3 months by 350 cubic centimetres, and this was 456 cubic centimetres in MIT. So just to put that into relative terms from baseline, That was a 10% reduction with the HIIT group and 13% reduction with the MIT group. Over 12 months, it was really great to see that they kept improving their visceral fat. Both groups kept improving, but again, there was no difference between the groups. In terms of liver fat, what we find was there was a 2-fold reduction in liver fat with the HIIT group compared to the MIT group. So the HIIT group reduced their liver fat by 2.8%, in which you can see down the bottom the baseline was 5.9 to start with, so almost half. And the MIT group reduced by 1.4%, and it did approach statistical significance. By 12 months, there was no further reduction. However, the HIIT group still maintained that 2-fold reduction. And so I know this is a busy slide, but we did measure a lot of other cardiovascular risk factors, but we didn't see a lot of change in things like blood pressure and cholesterol, and that was likely due to the fact that patients were already on medications for those things. However, in terms of the BMI and the waist circumference, we did see a small change over the 12 months in both groups, but no differences between groups, and HDL cholesterol also increased. For blood pressure, there was a significant difference at 4 weeks, actually favouring the MIT group. However, that was not evident at 12 months. And in terms of dietary intake, there was no meaningful changes in either energy intake or other macronutrients over the 12 months, and no differences between groups. So to summarise these findings, HIIT was equally feasible and safe compared to MIT. HIIT was able to be performed in a home-based setting with similar adherence to MIT. HIIT did offer superior benefit in terms of fitness and vascular function following the 4-week program, but was really only superior in the long term for those that stuck with it. And HIIT did tend to be superior for liver fat reduction. HIIT and MIT offered similar improvements in visceral fat, body composition and HDL cholesterol, and neither HIIT or MIT resulted in any short-term or long-term dietary compensation. So part of translating this study into clinical practice, we have also developed and published some guidelines for clinicians on how to implement HIIT into clinical populations. And we actually routinely use HIIT in our cardiac rehab program here at the Wesley now for patients that are interested and appropriate. So in conclusion, this study provides evidence that HIIT is feasible, safe, and provides superior benefit for fitness and vascular function compared to MIT. These findings support the inclusion of HIIT as a routine form of exercise prescription, at least as an adjunct to moderate intensity training. And our guidelines provide clinicians with a framework to prescribe HIIT in cardiac rehab, supporting them to identify and monitor patients appropriate to maximise safety. This work would not have been possible without the support of others. I'd like to acknowledge the Wesley Hospital Cardiac Rehab Program for their assistance in recruiting and also the exercise training components. I'd also like to acknowledge the University of Queensland for their testing facilities and the expertise of my supervision team. And last but definitely not least, I'd like to acknowledge the funding sources. Thank you to Wesley Medical Research who provide the bulk of our funding, but I'd also like to acknowledge others that contributed to the MRI component, such as Neatstone, Centre of Advanced Imaging, and NHMRC. Thank you very much. And now I'd love to introduce one of my participants from the study, Brett Beckingham. And the interesting thing about Brett was he was actually in the control group. So he was in the moderate intensity program. And so I just love to be able to see that even patients that aren't in the intervention group can benefit so much from being part of a research project. So
just over 2.5 years ago, I thought that I was doing a pretty good job in looking after my health. I went to the gym a couple of times a week, I thought my diet was quite reasonable. I went to annual checkups with my GP, who measured cholesterol, which was in reasonable limits. My blood pressure was no problem. So despite the fact that my father had a triple bypass here in this hospital 23 years ago, and ongoing high blood pressure issues, my mother had issues with her heart all of her adult life. I thought, it won't happen to me. I'm fine, I'm looking after myself. So it was quite a shock when I was at the gym one morning doing a cycle exercise class, as I had done a couple of times a week. And about 3/4 way through the class, I started to get a bit of a pain in my chest, and I thought, that's unusual. I hadn't had that before. And I'd sort of backed off the intensity a bit, and the pain went away. So I thought, not too much of a problem. The following Sunday, my wife and I had been out for dinner with some friends, and we were walking home. And where we live, there's a bit of an incline, not that steep, but I was walking up the hill. The same pain came back. And it made me think back to my father, who had a lot of angina in his life, and he was always trying to explain to me the sensation, the feeling of what angina was like. And it's not just a pain, it's a whole tightness across your chest, which I'd never experienced before. After some discussion, we decided the pain went away, so I didn't need to go to the Wesley emergency. But certainly the next day I went to my GP. That was on the Monday. The Wednesday I was in the Wesley here having a stress test, which didn't last very long. And on the Friday, many thanks and gratitude to the staff and doctors here at the Wesley, I had a stent put in on the Friday afternoon. I remember feeling that afternoon when I was in the pre-operating area here, thinking, why me? At 55 years of age, I was probably the youngest person having procedure done that afternoon. And I had a chat to the cardiologist, and he said 3 things. One was, with my family history, it was never a case of if I was going to have an incident, it was when. Secondly, he said, you're one of the lucky ones, and I was thinking about your friend Peter. He said, you've had warnings. A lot of people don't get that warning. They just have a heart attack. And he said, thirdly, consider the positives about what age group you are, because you're at an age where you can manage this situation and you can do something with your lifestyle to get better quality of life going forward. So we went into the operating theatre, and of course my main coronary artery was 70% blocked and the secondary was 30% blocked. So I was out of hospital on the Saturday afternoon, and it resonated in my mind about the fact that I can manage this, I can make things better. It was suggested that I do the coronary rehab program here at the Wesley, which is where I met Jenna. She mentioned that she was doing this research in conjunction with UQ, and would I consider joining it? My immediate thought was a 12-month study, that's a lot of commitment, and do I really want to do this? But then I thought, well, if I'm serious about finding out what I should be changing my lifestyle, it was important that I should contribute to research to find out what is the best way to do it. And ultimately, I believe it was the best decision I've made in many, many years. It surprised me when she did the initial visceral fat and fitness level, all that. I thought I was pretty good. No, I wasn't. And it gave me a framework then, what Jenna was doing, to actually put together a program. As she said to me, it's all about calories in, calories out. Sounds simple, but it's not many of us actually apply it as well as we should. I was so impressed with Jenna and the research that she was doing that fairly early on in the program, I said to her I'd actually like to donate money to her research because I wanted to make sure she had every financial resource she needed to present the facts that she presented here tonight. I got so much benefit out of the rehab program here at the Wesley, plus also the program that Jenna did, because it enabled me to see firsthand the results of what I should be doing. And it's fine to say it's not just about losing weight or feeling better. My waist measurement went down by 15 centimetres. My visceral fat level went down by nearly 50%. And it made me realise the importance of why I was doing this, but also about maintaining it. And if Jenna's research can be used to make people realise that by changing their lifestyle, managing their condition, we're all better off for it. So thank you, Jenna, and I'm so pleased. And my only disappointment now is the fact her research only went for 12 months. I would love to see when she goes out to a 5-year period. So ultimately, for me, the only negative that I had with what's happened is the fact that I've had to get a whole new wardrobe because nothing now fits me. Thank you very much.